and you.
We are live.
A very good evening, everyone. Welcome to iFocus Online Lecture 307, Ocular Oncology Module number 14. And today we have a discussion of long and short cases in ocular oncology. And to promise us to make it fun along with science, we have the dynamic duo, Dr. Sumeet Lahane from Raghunath, Netralaya, Mumbai, and Dr. Akshay Nair, again from Mumbai Advanced Eye Hospitals and Agrawal Group of Hospitals from Mumbai. So a brief introduction of our teachers today. Dr. Sumeet Lahane has done his MS ophthalmology from Sir J.J. Group of Hospitals and went on to do his fellowship in cornea and refractive surgery from Narayana Netralaya, Bangalore, and his ocular oncology and oculoplasty fellowship from Center for Sight, Hyderabad. He was an assistant professor in Sir J.J. Group of Hospitals from 2018 to 2022, and currently he's the director of Raghunath Netralaya, Mumbai. His area of interests are ocular surface tumors, tomography, keratoconus, and of course, he enjoys postgraduate teaching. The positions held in the past by him are, he was a secretary of Bombay Ophthalmologist Society, managing committee member of Maharashtra Ophthalmic Society, and also a scientific committee member of the same, organizing committee member of Oculoplastic Association of India. A very warm welcome to you, Dr. Sumeet. Also, we have with us Dr. Akshay Nair. He's an ophthalmologist, author, and clinician scientist. He has done his fellowship in Orbital Oculoplasty and Ocular Oncology from L.V. Prasad Eye Institute, Hyderabad. And currently, he's the director of ophthalmic plastic surgery and ocular oncology services at Mumbai units of Dr. Agrawal's group of eye hospitals. He's known for his pioneering work on mucormycosis, and he has over 130 indexed scientific papers in peer-reviewed journals and contributed in 15 book chapters. He has many awards and accolades to his credit, like the Achievement Award by American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology in 2019, and also winner of multiple travel grants, winner of Best Paper Award in Neuro-Ophthalmology in 2011 and Ocular Oncology in 2021 in AIOS, and the Best Poster Award in AO in 2013 and 2018. Also, another feather in his cap is that he was featured in top 2% scientists list by Stanford University for 2022. A very warm welcome to both of you, and over to you.
Thank you so much, Shafali, for that introduction and also enlightening introduction, because I didn't know Sumeet was interested so much in keratoconus also. All right. So what we're going to do here is, like you have in an examination, I'll be going through two long cases first, where you get to, we'll go through the typical questions that a candidate would face in an examination when they see a case like this. Now, typically, ocular oncology is something that is not commonly kept in the examination, but you never know. Also, ocular oncology is something that is usually kept for OSCE or for spotters or slides or specimen. So a lot of what we discuss in the long cases may also help you in that. So, don't always close your mind to the fact that we get only cornea, retina, and squint in long cases. It could be anything. So I'm going to pick on the four, that is Shubhav, Shefali, Sahana, and we've lost Varshini.
Probably she'll join back. We'll see.
All right. So as should be the case in your exams, you will be asked pointed questions. You're not going to be asked essay type question orally. You have to answer to the point, crisp. Don't start out at point A and travel and tell a story. Dr. Santosh Unawar calls this TWT, or time wasting tactics, which is not appreciated by the examiner. So to the point, and you'd rather say I don't remember or I don't know, rather than deliberately give a wrong answer. All right, so I'm going to start off with Subhav. Are you okay to, as a current oncology fellow, this is going to be a piece of cake. So try to go back 2-3 years in time when you were an MS candidate. Okay, so this is a 3-year-old male kid, and this is the picture that you see. The parents have noticed a white reflex since the past 4 months, and they've got them to us. So based on this clinical picture, what are your differentials?
So it can be a case of retinoblastoma with neovascular glaucoma.
Mm-hmm.
Second, it could be Coats disease with neovascular glaucoma.
Right.
Then third is other differentials for leukocoria, white reflex.
Mm-hmm. Such as, give us a couple more.
Yeah, congenital cataract with raised pressures or PHPV.
Right. So all of these are very, very correct. And the important thing to know is that you may know this is retinoblastoma, and don't shy away from saying retinoblastoma first, because the dictum is leukocoria in a child is retinoblastoma until proved otherwise. So very rightly said by Shubha. And I'm going to continue with you for a couple of more questions. What investigation would you advise based on this presentation to you?
First would be a B scan,
All
ultrasound B
right.
scan, to know the intraocular mass, presence of any calcification, the structural changes. Is there a retinal attachment or?
Okay. And after a B scan, what else? What would you plan then?
In this case, examination under anesthesia.
Okay. All right. So I'm going to put up a B scan, and I want you to describe this, what you see in this.
It's a intraocular mass filling less than 50% of the vitreous cavity. The intraocular mass shows specks of calcification. However, we would also require a scan overlay vector, and the retinochoroidal scleral complex appears to be attached.
All right. So I think he's given a very, very crisp answer, and this is the kind of answer that you'd want in the examination. The only other thing that should always be mentioned whenever you see a case of where one eye is shown is to always say, I would always like to examine the other eye. But of course, he did mention examination under anesthesia, but just to be very, very explicit, so the examiner knows you're thinking holistically and not just looking into the eye and the diagnosis. All right. So the other differential that you mentioned was, I think, Coats disease, right?
Yes, sir.
So just how would you differentiate? Just give me a second. Right. How would you differentiate or list the differences between Coats versus RB?
First is clinically or radiologically, sir?
Either ways, we can, it's as long as the viewers are able to pick on important things that you should mention, anything that you go. Yeah. Let's start with the basics, the demographics and the clinical features, and then go on to radiological and prognostic treatment features.
So if it were to be Coats disease, if I'm thinking in terms of Coats disease, it could be a child in the first decade of its life. Second, unilateral involvement more commonly. Third, xanthochoria reflex. And it can also present with high risk factors like NVI and raised pressures or NVG eventually. And a B scan in that eye would show homogeneous mass with no definite calcification and an associated retinal attachment and subretinal exudation, if we can pick up on the scan and overlay vector, and then proceed with the examination under anesthesia.
That's correct. So I think you mentioned most of the right things correct. Just one thing that as an examiner, I'll also mention is the acronyms in an exam will invariably lead you to questioning on what they are and then take you away from the answer. So NVI, NVG, it's better that just you spell these out. These are silly and small little things, but in your examination, it's important to know. So, as rightly said, so the other thing is Coats and retinoblastoma, both are in their first decade, but yes, the average age of onset or presentation is far more in Coats disease. It's an elderly child, or in between 5 to 7, as opposed to the average age of a retinoblastoma presentation, which is about a year and a half or so. An elderly male with a unilateral disease is classically Coats disease, and like he mentioned, xanthochoria versus leukocoria, iris neovascularization, also the vitreous cavity, and also one of the classic differentiation features is clinically you will see small, thin, tortuous vessels over the exudative mass, which is classically called telangiectasia with irregular dilatation. The moment you see that, it's a clincher for you that it most likely is Coats disease. And one of the things is that even, as experienced as you get, in some cases you really are in a quandary and you cannot differentiate the two. So Coats and retinoblastoma are really quite similar to each other. So my next question is, then whom do I go on to next? Is Shefali, are you going to be our next guinea pig? All right.
Okay.
Again, but I think this is going to be too easy for you nonetheless.
I hope
So
so.
we've been talking about retinoblastoma. What are the different classification systems that you know of? Now I put this medal sign because if you've reached up to here with all the correct answers, you're like a gold medal student. So you should answer all of these.
Yeah.
So yeah.
So we have the historical Rees-Elsworth classification,
Right.
and the newly followed is the international classification of retinoblastoma, which is called ICRB classification.
That's correct.
So that is what we follow generally clinically.
Right. So why did the shift happen from Rees-Elsworth to ICIOR or ICRB?
So ICRB is like a more practical way of classifying. It groups the tumor, and the Rees-Elsworth was based on the staging of the tumor. Basically,
Right.
yeah.
And also traditionally, Rees-Elsworth was at a time when chemotherapy was no longer not available, and the standard treatment was either enucleation or external beam radiation. So based on the treatment options available was how Rees-Elsworth was structured. That's correct. And for additional points, can you give us a brief split up of ICIOR or the groups that
So
you know?
we have 5 groups in retinoblastoma, which is grouped from A to E. Group A will be a small tumor, as any grouping would start. So we should remember it's a small tumor. Like for postgraduates, we have to remember like it's 3 millimeter in size, away from the disc, away from the fovea, more than 1.5 millimeters away from the fovea, and more than 3 millimeters away from the more than 1.5 millimeters away from the disc, and more than 3 millimeters away from the fovea. And no fluid will be there, no seedings will be seen. B will be a slightly bigger, B for B, bigger tumor. It will be confined, like as I said, near to the fovea or optic disc. C will have seeding. We can remember C and seeding, which is confined seeding. So it will be like seeds close to the tumor, less than 3 millimeters from the tumor surface, or fluid that is limited to the tumor, near the tumor. D is diffuse, D for diffuse, which is diffuse seeds that are seen more than 3 millimeters away from the tumor. And E is like an extensive, we can remember like that. More than 50% of the vitreous cavity, it is filled by the tumor. Or we have other features which show that it is like an extensive tumor, like we can have NVI, NVG, tumor filling more than 50% of the vitreous cavity. So all those will be grouped under group E.
Absolutely. We couldn't have asked for a more to the point and correct answer with each and every statistic of the size and location and the presence and absence of seeding, subretinal fluid, etc. So this is the standard ICIOR or grouping that is used, and also this grouping helps in, once you identify a group, it will help you in choosing the correct treatment option also for this. So the just to add and wrap up this case, the other eye is normal. This is an only child. The parents have also a normal, no unusual family history. What would be your treatment plan?
Ideally, we can start chemotherapy. So we have like 2 options in this case. Either it can be primary enucleation, since you have specifically mentioned that the other eye is normal, and if it's bilateral retinoblastoma, we tend to consider chemotherapy as our first option. But if it is unilateral, it is so advanced. After going ahead with MRI, so that we rule out other high-risk features, that is optic nerve extension or extraocular extension, because I can see little bit of kind of like subtle proptosis in this eye, just to rule all of that out. If we have ruled that out, we can go ahead with primary enucleation. Second option would be neoadjuvant chemotherapy. I call it neoadjuvant because such kind of advanced retinoblastoma might not have a very good vision salvage. So if the parents are very keen on keeping the eye, just giving it a try, we can give them an option of chemotherapy and see how it goes. And after 6 cycles of chemotherapy, we can decide about enucleation, whether it's required or not, or primary enucleation with like implant, and give a nice customized ocular prosthesis to the child. Of course, if it's enucleated, we have to send the sample for histopathology just to see the histopathological high-risk features and decide about chemo if any histopathological high-risk features are present.
Excellent. So I think that sums it up very, very well. I have absolutely nothing more to add. So with this, we go on to our next case, and I'd like to have Dr. Sahana step up for this. Is Dr. Sahana there?
Dr. Sahana, can you hear us?
She's muted though.
Yeah, I'll just ask her. Maybe Subhav can take the next one also.
All right.
Sure.
Okay, so this is your next case. This is a 63-year-old male with one eye, the left eye, appearing larger than the right eye since 1 year. He has no complaints of pain, redness, or any other visual complaints. Vision in both eyes is 6/6 and 6. So how will you examine this case clinically? So obviously what you see in the picture below, do you know what this view is called, this particular view of this photograph? Where you see his nose and the eyes?
Yeah, the bird's view or the worm's view?
So both of them are actually the opposite of each other. The bird's view is the view from top, which is like a Navziger's view. Yeah. And this is, like you said, the worm's eye view, where it's the appearance of the world like a worm would from the ground looking up. So this is the worm's eye view, and very, very helpful in identifying proptosis because you have the position of each eye relative to each other. So clearly you can see that there is proptosis here. So, that's not a difficult question. So the question is, how will you clinically examine this case? So how about let's start off by, for the benefit, everybody wants, has those checklists. So can you help me go through a proptosis checklist?
Yes, sir. Assessment of acuity with pinhole or the best corrected vision acuity. Second is assessment of the color vision. Third is examination of the pupils to look for any relative afferent pupillary defect or then examination of the tear film assessment by Shermas and Hertel's exophthalmometry. Look for any change on bend or Valsalva maneuver. Look for any visible pulsations or a thrill or a bruit. Then examination of the palpebral fissure height, the margin reflex distance, any lag of ophthalmos, corneal sensations, health of the cornea, and the sensory supply involving the trigeminal nerve, and assessment of any palpable mass or signs of inflammation or retrobulbar resistance, any pulsations.
All right. So I think that's essentially covered everything. Two things that probably slipped his mind were intraocular pressure measurement.
Yes, sir.
It's important to know because proptosis is often associated with specific lesions that cause proptosis that also cause raised intraocular pressure, and examination of ocular motility, because that will also give you an understanding of the location of the lesion, the extent and the involvement of the surrounding structures. And both of them are extremely important. So like you said, start with the pupils, get the vision. Color vision is essential because even before optic neuropathy can set in, the first sign of optic neuropathy is a subtle loss of color vision. Intraocular pressures, ocular motility, proptosis by measurement of exophthalmometry, slit lamp examination, fundus examination, where you examine the cornea, the anterior segment, And finally, inspection, palpation, auscultation, and assessment of if there's any bruit, etc. He mentioned Valsalva or checking while bending. You also want to palpate and see if you get a thrill. Auscultate to see if you can hear a bruit. All right. So has Sahana returned?
No, I think she is not joined.
Okay.
So
I'll continue, sir.
Please go ahead. So what are the likely fundus changes that you see in long-standing proptosis?
In a long-standing proptosis, there may be presence of disc pallor, or second, there can be optociliary shunts.
And early on, when there is a sudden acute increase in proptosis, what else would you also see?
In an acute onset proptosis, first would be if there's a possibility of a disc edema, second, presence of choroidal folds.
So disc edema, that's correct. So disc findings, it could either be edema, which then evolves into atrophy and pallor. Choroidal folds may be seen even early on or late, depending on the chronicity of the proptosis. Early rapid onset proptosis can also cause retinal hemorrhages. And finally, like he mentioned, optociliary shunts by way of choroidal or collateral vessels that are seen are also a sign that the proptosis has been there for a longer time. So what are the systemic conditions that you want to assess in a case with proptosis, either unilateral or bilateral?
First would be first differential would always be a thyroid eye disease. So we want to know whether the status of thyroid in that patient, whether he's a euthyroid, hypo, or hyperthyroid. Second, associated neurofibromatosis.
That's correct. So the most commonest two conditions that have systemic conditions that have implications on the orbit in terms of proptosis are thyroid eye disease and neurofibromatosis. Neurofibromatosis can have multiple ways it can cause a proptosis by way of optic nerve gliomas or optic nerve tumors. They also have an absent greater wing of sphenoid, which can cause the dura along with the brain to extend into the orbit, to prolapse into the orbit and cause proptosis, and in that you can actually see the pulsatile proptosis. All right, so what are the causes of axial proptosis?
Any intracorneal lesion can present with axial proptosis.
That's correct.
So a cavernous hemangioma or a optic nerve glioma, optic nerve sheath meningioma, and neurolemoma.
Okay, so now if you were to classify the orbit in different quadrants, let's go from one quadrant to the other. If we talk of a medial mass that is displacing the globe laterally, what is the most common cause of a medial lesion causing proptosis, abaxial proptosis in that region?
Any extension of disease from the paranasal sinuses, adjacent sinuses, front sinus, mucocele, or ethmoidal sinus disease, or sino-orbital extension of any disease.
Right. All right. So while he's given all the correct answers, also remember, while we are thinking tumor, don't forget infection. So orbital cellulitis, especially one that causes a medial subperiosteal abscess, can also cause a similar kind of a mass effect. And this is just a schematic diagram. This is obviously not a comprehensive list. So as rightly Subhav said, intracorneal masses, which are typically cavernous hemangiomas, schwannomas, or optic nerve tumors, optic nerve gliomas, meningiomas, or even AV malformations can cause axial proptosis. Now, to differentiate, understand what is axial versus abaxial is. Axial is along the axis of the optic nerve, which is anteroposteriorly. So you'll have axial proptosis of the eye that is only outward, no downward, medial, or lateral or upward component, as compared to abaxial proptosis, where there is a mass which is off the axis. It could be either superolateral, like a lacrimal gland, which enlarges in that quadrant, pushing the globe downward and outward. Similarly, there could be a frontoethmoidal mucocele arising from the superonasal quadrant of the orbit, pushing the globe downward and outward in this case. So, there you have a mass medially pushing the globe outward and downward in that quadrant. Whereas if you have a lacrimal gland, the mass itself is superolateral, so it will push the globe downward and inward. So based on this, this is not obviously a comprehensive and exhaustive list, but you get the idea of the most common lesions in different quadrants and what you should think when you have abaxial proptosis. That will give you an idea. So we go back to our first patient whom we saw. So what would be your next plan of action in this patient?
In this patient, if there is any ocular motility restriction and if there is pain and diplopia, then I would do a diplopia charting in this case. Second, proceed radiologically with an MRI of the orbits, plane and contrast, to know the lesion, the extent, the relation to the adjacent structures, and assess radiologically as to what is the cause. And depending
Okay.
on the cause,
Any reason why you would do an MRI over a CT?
CT is good for bony lesions and bony details, and MRI would be much more better for soft tissue lesions.
So in this case, suspecting a bone, soft tissue lesion, which is why you're looking at that. MRI?
Pardon, sir? Sorry, the voice was not clear.
Oh, sorry.
I'm
I
sorry.
said, in this case, are you suspecting a soft tissue lesion?
Yeah, it seems to be an
Yes,
axial
it seems to be
proptosis.
axial
I might
proptosis.
like my differential would be an intraconal lesion for this
All
case.
right.
So
Okay.
just to see the relation to the optic nerve, but CT can also, like CT can be preferred if obviously because MRI is more expensive. So CT can also give us a good enough information.
All right. So this is what we have. And would any of you want to volunteer to describe this?
It's a void-shaped lesion, predominantly intraconal, extending from the anterior extent is up to the uh, posterior surface of the globe. Posterior, it is just a shorting stop of the orbital apex. The orbital optic nerve is not clearly seen apart from the mass, and there's no bony erosion. Yeah.
I think the optic nerve is seen in some segments, so it's differentiate, and which again brings us to a very important part, which is in places where you do not see the optic nerve clearly, is again an indication for you to do an MRI, because that will help you delineate the mass from the optic nerve. And if you're able to see the fat planes between the mass and the nerve, it gives you an idea that is distinct from the optic nerve, and you can plan surgically accordingly, as well as prognosticate to the patient the chances of visual loss or visual reduction in visual acuity intraoperatively or postoperatively.
So in this case, what would be your surgical approach that you would prefer?
Inferior orbitotomy with transconjunctival approach can work in this case.
All right. So in inferior orbitotomy with transconjunctival approach, as you can see here, let me get that. The mass is in the inferolateral quadrant between the lateral rectus and the inferior rectus. So in this case, you know that you can clearly go, inferior transconjunctivally and then take the mass from that quadrant without having to remove the bone there. So that is the preferred route. And in this case, that is precisely what was done. An inferior transconjunctival orbitotomy was done, and through that route with a cryo-assisted delivery, you're dissecting the mass bluntly, dissecting all the adhesions and attachments from all around, and then using your third hand or figurative third hand, which is the cryo probe, you attach the cryo and create the ice ball on the anterior surface, which is free. and with sideways movement as well as anterior posterior traction, these mass lesions usually pop out. And what does this look like?
A cavernous hemangioma.
A cavernous hemangioma or cavernous venous malformation, as they now call it. So cavernous hemangiomas are typically benign when encapsulated lesions with wide vascular spaces in between. And they are typically intraconal and displace the optic nerve in one direction. In CT, we saw that they are well demarcated, but as rightly mentioned, soft tissue lesions, especially vascular ones, need MRI with contrast so that you can appreciate that they are high ISO to hyper intense in T1. And in T2, they are moderately hyper intense with flow voids or the stippling that you see within the lesion that you can see over here, the typical appearance of the flow voids and stippling that is there. All right. So I'm going to have some quick questions. Do we have anybody else apart from you two who can take these questions?
Ruju is there.
All right. So, Ruju, what is the most common cause of proptosis in children? 3 questions for you.
Yes, sir. Orbital cellulitis is the most
Orbital
common cause.
cellulitis is the most common cause. What is the most common cause of unilateral proptosis in adults?
TD, sir.
Again, no acronyms in your examination, no short forms. Otherwise, your exam scores will also be in short form. Thyroid eye disease, the answer is correct. Which then brings me to my second question, which is the most common cause of bilateral proptosis in adults?
Just same thyroid eye disease.
Same, thyroid eye disease. The googly has been spotted. So bilateral thyroid eye disease is correct. Can you tell me what is this instrument that is being held in front of his eyes?
Yes, sir. So this is Hertel's exophthalmometer.
And what is that number that you see, 80, 90, 100 that you can read?
Yes, sir. That is the base reading.
Okay, what is that base supposed to indicate?
Sir, canthal distance.
So intercanthal distance would mean what?
Distance between the lateral canthus.
Just give me a second.
Like orbital rim. Sorry, not canthus. Orbital rim. Lateral orbital rim.
All right. Just give me a second. Yeah, all right. So when you say lateral orbital rim, yeah, so basically it's the lateral canthus. From the lateral bony canthus, the distance between the two. Now, a bony landmark will never shift even though proptosis may progress. So to ensure minimal inter-observer variability, it is always good to mention the lower or the base which is mentioned. In that will be the number that you have, the 80, 90, and 100. And then what do you do after that? What is the other number that is mentioned?
So then we look for 2 red lines that should match, and we see for the apex of the cornea, basically the corneal reflex, and the reading is matched.
All right. So you try to eliminate parallax such that the 2 red lines coincide, and then on the graduated marking scale, especially the one that you can see on the right eye of the in the prism on the right side, you see which coincides with the apex of the cornea with the patient looking in primary position straight ahead. All right. Can you tell me what is this weird looking thing?
The Lutz exophthalmometer.
So how do you use this?
It is basically placed at the lateral canthus, and from the side the readings are measured.
So basically lateral canthus, the canthus is a soft tissue anatomical landmark. What you
Yes.
want to see is the lateral orbital rim.
Or-
So it's on the lateral edge of the orbital rim in line with the lateral canthus, and again with the patient looking straight ahead, like you rightly mentioned, you will check the distance from the edge or the apex of the triangle, which is at the tip of the exophthalmometer, till the apex of the cornea, and that will be your measurement. Okay. So for bonus points, what is this?
The Nigel's exophthalmometer.
What is the name again?
Nigel's.
Okay, it's Noggles or Nagels. Yeah, I will give it to you. So what is different in this?
Sir, dystopia can also be measured.
Dystopia can also be measured, and also it can be useful in patients who've undergone a decompression or a lateral orbitotomy, where the lateral orbital rim, which is the bony landmark that you use for hurtles, itself has changed position. So here, because you're using the maxilla and the forehead as the anatomical landmarks to stabilize, you don't need to rely on the lateral orbital rim. So in patients who've already been operated, this may be useful. All right. So just to go back to our examination techniques, things that you should look for are palpation. In palpation, you look for the rim, you look for tenderness, for pulsation, thrill. Don't miss out regional lymph nodes, because that can also give you an idea that it could be a tumor. Check for complaints on paranasal sinuses and also paranasal sinus tenderness. In cases of trauma, this has to be your checklist. Orbital trauma, palpate the rims for a stepladder deformity. Check for crepitus. Crepitus is crackling sound because of that you can palpate the air, and the air in the subcutaneous spaces essentially is emphysema. Check motility. Check for trismus, because trismus indicates that the orbital trauma is beyond the orbit involving the maxilla. Diplopia should be charted, like was mentioned. Measure the enophthalmos, and always check for infraorbital hypoesthesia or anesthesia, because that tells you that the infraorbital nerve has also been damaged. So this is your checklist for orbital trauma. And finally, what is this? Is the video playing at your end?
I think there's some lag. Can't see anything move. Is it pulsed? Acha. Ha, now it's playing.
Let me play that again.
Yes, sir.
Right. So what is this being seen demonstrated?
Valsalva's maneuver.
Right. So what does Valsalva cause, and what is the phenomenon that what results in what we just saw? Is someone answering, or am I losing audio?
Super, we're taking that.
All right. So I'll just wrap it up quickly. Basically, Valsalva causes raised intrathoracic, intraorbital pressure, and that causes venous pooling, which causes dilation of venous channels or distendable venous channels. In cases like orbital varices, you can see that the Valsalva maneuver causes these varices to become engorged, and that causes this kind of a shifting proptosis. It is also dependent proptosis, because these vascular channels don't have valves that can help in anti-gravity. So when you bend down, you also see that the proptosis goes up. So with that, I'll stop screen sharing. And before I come back to spotters, if we have time, I'll have Dr. Sumeet Lahane take over.
Thank you, Akshay sir. He made my job simple. I would be covering a few of the long and short cases. Is my screen visible?
Yes.
Yes, sir.
So we'll go case wise. A lot of examination evaluation part of the orbit is already been covered. So this is a 14-year-old girl who presented with the swelling and the protrusion of the left eye. And this is what you see. Subha, would you like to describe in 2 or 3 lines what are you seeing in this patient?
Yes, sir. Looks as if the girl has a left eye protrusion
Correct.
with the fullness of the left upper lid. Uh, there is evident swelling with the erythema on the surface of the skin.
So as he rightly described that on inspection, what you see is a fullness in the left-sided and specifically in the superotemporal quadrant. That's how the young girl is presenting. So when you have this young patient presenting with swelling in the orbit, what would be differential diagnosis? Shefali, can you give me any two of differential diagnosis? Two or three?
First thing, since it's in the supratemporal area, I would think of a dacryoadenitis, although it doesn't seem to be bilateral. Slight, if fullness I can see in the other eye also. Viral dacryoadenitis will be mostly bilateral. Second would be orbital cellulitis, would be my second differential.
So when we examined, otherwise anterior segment fundus, everything was normal. We did one more test, which was Schaumas, and it was normal in the right eye and it was reduced in the left eye. So with this positive findings, we went ahead and we did imaging, as even we suspected it is a lacrimal gland pathology, and this is how we could see it. We will be covering the imaging in the spotters meanwhile after this, but just to have a brief introduction of the same here, you see okay, I will go ahead with the description myself. So there is a homogeneous kind of irregular mass you can see in the superotemporal quadrant here, with minimal bony excavation, not too much, and it is shifting the optic nerve little medially, and of course it is involving the lateral rectus. In this section you don't see a lateral rectus properly, but it is a bit separate from the lateral rectus. So we went ahead and we did an incision biopsy as we do, and then we were waiting for the histopathology. Patient presented again with this kind of a swelling somewhere on the back of the patient, the central back. At this point, any differential diagnosis, Shefali, you would like to pinpoint something?
I would actually think of a lacrimal gland tumor in that case, because the tumor was the mass was actually crossing the midline. It was quite large. So maybe a metastasis can be one of my differential.
Okay. Subha, you want to differ? It's okay. You can have a different opinion even if she is your senior. Fine. So we'll go ahead with this, and then the incision biopsy report came, which showed nothing but there was a Langerhans cell, giant cells, and epithelioid granuloma. Meanwhile, we also did a HRCT of the patient, which showed tree in bud appearance, and patient basically had a dacryoadenitis only, which was your first differential diagnosis. And it was a TB dacryoadenitis. As we know, we live in India, which is endemic country for TB, but still the TB dacryoadenitis cases are very rare. So here the important points are what Subhav described is very important, that there was a erythema and that was an inflammatory swelling. So important point I want to tell you here is that since this was an inflammatory lesion, the Schaumas was reduced in the one eye. So as in the proptosis evaluation, one of the important thing that if you suspect that it's a lacrimal gland lesion, the Schaumer test is important. As in the inflammatory lesions, the Schaumas will be reduced early in the period. On the other side, if there are tumors or there are large malignant tumors, unless they are huge enough to destroy the complete acini structure, the Schaumer test will be normal. So this is a very simple and the important test that can be done in proptosis or especially the lacrimal gland case.
What you showed here was the cold abscess, sir?
Yeah, that was a cold abscess. It's like a pot spine she was developing at the same time, and she had a tuberculosis even in the lungs. So with the AKT, it resolved completely. So now from the 14-year-old girl, we are moving to a 15-year-old female. And anyone would like to describe this? Subhav?
Yes, sir.
Mm.
Um, there is a fullness of the right upper lid with some amount of hypertrophy of the right eye, and I can see a scar mark in the subbrow area on the extreme lateral aspect.
Correct. So that covers all what is seen, except this part. There is a
S-shaped
drooping and S-shaped drooping that is seen on the upper eyelid on the right side. And on examination, the vision and everything was fine, but there was mitosis and extraocular muscle movements were restricted on the abduction, and there was a 2 mm proptosis. And as he rightly mentioned, that there is a scar mark, which you should not forget. The patient already had undergone a biopsy to have a differential diagnosis. So at this stage, what is the next line of management that you will do? We do not have a histopathology report available.
So evaluate it radiologically as well.
Okay, so
And
you want imaging. I will give you some additional point that this patient also complains of pain, paresthesia, and some protrusion, which we have noted on examination. So now we have a 15-year-old female, biopsy done somewhere else, with 3 symptoms and 4 signs of proptosis, ptosis, palpable mass, and movement restriction. And now I give you imaging. Would you like to describe this?
yes, sir.
Go ahead.
You have 2 images. One is a mid level axial scan, and the other is a coronal scan, CT scan, which shows a homogeneous lesion in the aspect of the orbit with a breach in the lateral orbital rim, an extension of the lesion into the temporal fossa.
Correct. So it's basically irregular mass, which is causing bony excavation and even the breach in the lateral orbital wall. So looking at the lesion looks quite aggressive. And whenever there is a bony involvement, there is a high likely possibility that we keep a neoplastic etiology as our primary differential diagnosis. So this was nothing but turned out to be adenoid cystic carcinoma. So the reason behind putting this 2 extreme cases, that the patient was almost the same age, 14 and 15 years. The presentation was more or less same. Both had pain, some amount of proptosis, but the differential diagnosis on the imaging was completely different. So the orbit is a Pandora's box, and even lacrimal gland lesion can present in variety of forms. So you need to be very careful with advising your imaging and having pinpointing your differential diagnosis, because the management for both is completely different. So there are certain important viva points that all of us should know about lacrimal gland tumors. Even that is an important question in the theory. Classification, which is the most common tumor, benign and malignant. What investigations and the approach which we have discussed, and the management. So in the brief, Shefali would like to talk about the classification of lacrimal gland tumors in a very brief.
Epithelial and non-epithelial. So we can classify like that, and benign and malignant comes after that. Most common would be pleomorphic adenoma that we see in the lacrimal gland tumors. And that is the most common benign tumor of the lacrimal gland. And we can have pleomorphic adenocarcinoma, which is the malignant version, and mucoepidermoid carcinoma, which is again a malignant version. So yeah, and it's
Common
epithelial
malignant tumor.
Sorry.
Most common malignant tumor.
I think that would be
one which we just discussed.
Yeah, adenoid cystic carcinoma.
So investigations and the approach that we have already discussed. So to tell you, the lacrimal gland tumor, as it is only 1 per 1 million is the incidence, but still it accounts for 10% of the orbital tumors. And as she correctly said, there are 50% of the tumors which are epithelial and 50% are non-epithelial. Non-epithelial do include lymphoid ones, mesenchymal, and the secondary tumors like metastasis. So lacrimal tumors, the very easy way to classify them is epithelial and the non-epithelial. In epithelial, again, the 50% of the tumors are pleomorphic adenoma, and 50% you can could be malignant. And again, in the malignant, the most common is adenoid cystic carcinoma. So this is a very simple classification which you should know in your vivas. Of course, there is a detailed classification available, but it's more for a theory point of view. In Viva, at least you should know about your most common tumors, and specifically pleomorphic adenoma. This is again very important in your clinic as well. Pleomorphic adenoma, the important points that you should know that 10% of those can undergo a malignant change, and it depends on the compounding of your years. More the years, more there are chances that you will get a recurrence of a pleomorphic adenoma into a carcinoma. So you need to be very careful. And the most important thing about pleomorphic adenoma excision, that as it is shown in the picture, that it should be excised completely. Otherwise, there are high likely chances of recurrent. Again, the most common recurrent tumor will be a pleomorphic adenoma. Adenoid cystic carcinoma, as we discussed, it is a most common malignant epithelial tumor. And since we were discussing, and very specific clues that I gave in the second case was patient had pain paresthesia, because adenoid cystic carcinoma is known to have a perineural invasion. And the management of the adenoid cystic carcinoma is completely different. It is not only excision biopsy that fulfills the requirement. It is incision biopsy followed by chemotherapy, radiation, excision biopsy followed by radiation. Because this is one of the tumors that can metastasize very aggressively. So just to summarize, your lesions could be idiopathic, lymphoproliferative, benign, and malignant, and accordingly you treat them. So this is a very simple chart which can help you out to answer all your Viva questions. Moving ahead with the next case. These are various eyelid lesions. So we are going to discuss few eyelid tumors which are very important and common. So this is 65-year-old male. Ruju, would you like to describe this lesion that you are seeing in this patient?
Sir, it is lesion located over the medial canthal area of the left eye with surrounding black pigmentation and rough ulcerated edges.
Okay.
Likely diagnosis would be
Great.
basal cell carcinoma.
I don't want you to go to diagnosis directly, because that is very obvious. I want you to describe the lesion under this heading. So whenever you see any lesion, specifically an eyelid lesion, try and describe under this 9 headings. It's color of the lesion, size, appearance of the vessels, margins, is there any involvement of the conjunctiva, is there any distortion of eyelid structure, ulceration, is there any change in the eyelashes, and is there any lymph node enlargement? So would you like to describe this again now?
Yes, sir. It's a lesion located over the medial canthal area of the left eye with size of approx 20 mm by 13 mm with a central row area and a surrounding ill-defined.
Okay, so I want you to cover margins. How are the margins?
Margins are hyperpigmented.
They're pigmented, rolled out margins.
Margins, yes.
Fine. Any comment about eyelid structure? What has happened to the medial part of the eyelid?
There is loss of normal eyelid architecture with loss of eyelashes and thickening of the.
So more than the thickening, there is some ectropion on the medial side which is getting
Yes.
developed. This generally this individual presented with the complaints of there is watering constantly since many years. That is because of the its punctum is already blocked with the tumor. That's how he presented. Okay, so I think you are cover everything except thing that there is involvement of the conjunctiva also. And one thing that you would like to examine is the lymph node. Because whenever there is a lesion and basal cell carcinoma, which is aggressive locally, high likely chances that it will have a lymphatic spread. So any eyelid lesion, as she correctly said, this is basal cell carcinoma, and there are certain viva points which I want any one of you to answer. Subhav, let's go one by one.
Yes, sir.
Would you like to tell about lymphatic drainage of eyelids?
Yes, sir. Predominantly, the lateral third of the lids drain into the preauricular nodes, and the medial two-thirds drain into the submandibular group of nodes.
Okay. So just to be very specific, if you remember this diagram, you'll understand the drainage of the major part of the upper lid, that is lateral two-third, goes to the preauricular. And the major part, the medial two-third of the lower lid goes to submandibular lymph node. Okay, so basically you need to palpate preauricular, submandibular, and the cervical nodes whenever you have a eyelid lesion like this. This I have answered already. So most common eyelid tumor at such malignancy in the world is basal cell carcinoma, but in India it is sebaceous gland carcinoma, which is the second most common eyelid malignancy in India, Subha.
So basal cell carcinoma.
Correct. These are the types: superficial, nodular, and the infiltrative. And the newer treatment which are available, basically imiquimod and the vismodegib. So whenever you are presenting any eyelid pathology, these are the four things that you should know. Whatever is the tumor that you are describing, you should know the types of the same and certain recent advances of the same. So this is again like Akshay sir has put certain golden points or the gold medal points or brownie points. So hedgehog pathway, basically it's something that has been researched that it's an important pathway in development of the basal cell carcinoma. And to stop that pathway at the level of the transcription, the drug that has been introduced is vismodegib, which I have mentioned in the earlier slide as well. This is again oral therapy, which is given for the diffuse or the larger basal cell carcinoma. For the lesion which I have shown on the in the slide, basically it's involving the medial canthus, and there are high risk that this lesions involve the orbit, and there are high chances that this patient might need orbital exenterations. So vismodegib is a tablet which can actually chemo reduce this kind of a large lesions. So this is for your MCQs, any competitions, or even for your brownie points. That hedgehog pathway basically deals with the basal cell carcinoma, and to stop the pathway, we have a drug available now, which is called as a vismodegib. This is the last case. So this is 60-year-old male presenting with the recurrent mass and the multiple incision and curettage done. Ruju, would you like to describe this?
Yes, sir. It's basically upper lid lesion over the medial border
Okay.
with mostly involving the posterior lamella of the eyelid with yellowish globules over the surface and telangiectatic vessels with loss of eyelashes and thickening of the lid margin medially. Measuring approximately 8 mm into 6 mm, but further evaluation after everting the upper lid is required.
Correct. So you wanted me to evert the eyelid. I did it for you. Now you want to do tell me some additional features.
So the puncta is basically spared. It lies just adjacent to the upper puncta.
Okay. And there are irregular yellowish nodular multiple lesions with the telangiectasia. Okay. Again, that point out toward the neoplastic pathology and the differential diagnosis, as she correctly described, that there is a lid margin thickening, loss of eyelashes, nodular yellow color mass in the upper lid is very common presentation of sebaceous gland carcinoma. So again, lymphatic drainage of the eyelid, which we have already discussed. Can anyone, Shefali, tell me what are the other differentials or other ways of presentation of sebaceous gland carcinoma in the eye, other than the eyelid lesion which we have shown?
Red flag things that we should be very, very careful about is elderly with the unilateral blepharoconjunctivitis. Chalazion, as this case has presented, multiple INCs done, and chalazion which is not settling down. Yeah, and yeah, these are the two most common presentations.
Okay. So any of lesion which is in the elderly individual, especially unilateral, presence of blepharoconjunctivitis, having a chalazion which is recurrent, especially at the same site with the recurrent INC, and sometimes even superior limbic keratoconjunctivitis, all these are very close differential diagnosis or a the way of presentation of sebaceous gland carcinoma. So you need to be very careful in such cases. Common location is upper eyelid, again, as there are more number of the glands. And the newer treatment that is important in such cases is chemotherapy. Now, one of the important thing that you should again remember in such cases is the Muir-Torre syndrome. Muir-Torre syndrome is something that is associated with the sebaceous gland carcinoma. It's an autosomal dominant variety, which can have a involvement of the multi-system, could be gastrointestinal, endometrial, urological tumors. And that's why whenever you do a histopathology of any sebaceous gland carcinoma or any HPE shows you sebaceous gland carcinoma, one of the additional tests that you should do in these cases is, Subha?
Sir?
You're there, Subha?
Yes, could you please repeat the question, sir?
I said in histopathology, if the diagnosis is sebaceous gland carcinoma and you are suspicious of Muir-Torre syndrome, what additional tests that you should do in such cases?
So immunohistochemistry.
Yeah, additional investigation.
Investigation.
Yeah.
Systemic evaluation for malignancies like a PET CT scan.
Okay, before that, your pathologist will be happy to do it, especially Kaustubh sir would be happy to do it. Some gene. Shefali.
Genetically, if you have to test, it is the MTS gene. Otherwise, gastrointestinal polyps are common. So, like endoscopy would be.
Basically, mismatch repair gene mutation. That's what we need to see in such cases. So, your pathologist or you yourself can advise them that this further testing needed. And of course, if it is positive, then you can do a whole generalized systemic checkup to rule out that there are no other system involved in such cases. I would like to pass on again to the Akshay sir now, and let's go with the podcast. Of course, I'd like to acknowledge. Sorry.
So I would like to request you to tell the PGs about pagetoid spread also, just in case if they are asked about it, because we showed a nodular SGC.
Correct. So we have shown a nodular one. The one of that is like we said, a blepharoconjunctivitis. Sorry, I don't have a picture here. So whenever a patient present to you with the unilateral blepharoconjunctivitis, treated with multiple drugs, multiple drops, still not getting cured, it's an angry looking surface with multiple feeder vessels around all over the conjunctiva. There is irregular lid margin thickening without any appreciable swelling is a very important differential diagnosis, and that's basically a masquerade presentation of sebaceous gland carcinoma. So whenever that kind of a presentation is there, it's basically epithelial spread that has happened, and to best way to diagnose is do a map biopsy. So you take a multiple small bits of conjunctiva from the 16 different places and send it to your pathologist, mounting it properly to know that is there any involvement of the any quadrant or the whole of the conjunctiva. And that is very important to pinpoint the diagnosis in such cases where they are not getting treated with simple drops, or there is a recurrent blepharoconjunctivitis. So that's a pagetoid variety of sebaceous gland carcinoma.
Yeah. Thank you, sir.
So I'd like to pass on to the Akshay sir again. Let's go for the spotter, sir.
Yeah. Do we have enough time or
We can continue, sir. No problem. It's
Yes.
interesting. I think PGs will benefit only.
Okay. All
Life
right.
science. That much time we don't have.
All right. So I'm going to put some images, imaging modalities. So few rules is, see, many times, and nowadays, you don't have when in OSCE and all, we don't have the actual films. They usually keep a laptop and they put images and you are asked to describe. So first thing is, what is the imaging modality that you're seeing? What is the view or what is the slice, whether there is contrast or not? Describe what you see, and ideally you should be able to mention whatever laterality is there. But given that we may have inverted images or upside, in the sense the view can be down, up, so sometimes the right eye may appear left. So if you can describe the laterality, describe, or else mention the side on which you are seeing it as per what you see on the screen. And then you come to the possible pathology. Remember, what is the exam that you're appearing for? You're appearing for your ophthalmology residency examination. So you're an ophthalmologist, not a radiologist. Don't see the scan and say, oh, adenoid cystic carcinoma. That is not what they want to hear. You have to describe what you see. All right. So we start with Sumeet. You also want to come in this?
Yeah, sir. Anything.
No. Okay, so we'll start with Dr. Ruju. What do you see?
Yes, sir. So basically, this is a CT scan
Okay.
showing bilateral pathology with hyper hyper dense lesion in both the orbits intraocular. So my most likely diagnosis would be retinoblastoma.
Is this a coronal slice?
Uh, no, sir. This is axial.
Right. So you've described everything, but in all, in 0.1, 0.5, 0.3, 0.2, 0.1. So this is a CT scan. It's an axial slice. Passing through the slice is mid-orbit and passing through these, because you can see the lens shadow in this. So it's in the mid-orbit axial slice. And again, for the benefit of everybody, intensity is something that you see in MRI.
MRI.
Density is something that you see in CT.
Yes.
So hyperdense is CT, isodense is CT, hyperdense is CT, whereas all the intense, hypointense, isointense to brain or hyperintense is in MRI. So you're right, there are hyperintense lesions suggestive of calcification seen intraocularly in both eyes, and therefore my most likely diagnosis would be retinoblastoma. Very good. Okay. So, Dr.
One question, if I can add in the previous slide.
Yes.
What are the causes of intraocular calcific lesions, Subha, other than retinoblastoma? It may not be tumors. You can say anything else in that. So, okay. If there is a trauma, if there is intraocular foreign body, that can give this kind of appearance. If there is a lesion like choroidal osteoma, it can still give you some calcification. If there is medulloepithelioma, sometimes even they present with some amount of calcification. So this is certain differential diagnosis that you should be aware of intraocular calcification.
And thysis bulbi and optic disc drusen.
Correct. Yeah.
Okay. So what do you see here? Again, Ruju.
So it is a axial CT at the level of inferior orbit
Okay.
with a hypodense fusiform lesion in intraconal space in the right orbit.
So what do you suggest it could be?
Sir, it could be a optic nerve glioma.
Okay. Would you want to do any other investigation?
Neurofibromatosis can be the one of the differentials. So
For optic nerve lesions, the imaging modality of choice is
MRI.
MRI. So when you do an MRI, you will be able to appreciate the lesion much better. And also you can see the extent of it and whether it is, the intraocular extension of the lesion, etc. All details are more visible there. All right. Dr. Subhav,
Yes, sir.
what about this one?
This is a CT scan
Mhm.
of the taken at the mid-orbital level
Mhm.
and shows a homogeneous, well-defined mass
Mhm.
in the right orbit,
Mhm.
and it is displacing the optic nerve medially,
Mhm.
and there is uh, possible fossa formation along the inner aspect of the lateral orbital rim
All right.
caused by pressure changes of the mass.
Right. So would you call this fossa formation or look at the irregularity?
Irregularity of the bone.
Right.
Yes.
So there can either be soft, a slow growing lesion usually will cause scalloping or fossa formation. An aggressive, infiltrative, rapidly growing lesion will cause bony erosion with irregular appearance because it is eating into the bone. So this is what you would typically see in a irregular or a erosion of a bone. So that is correct. You described it well. Only thing missing was that it's an axial scan. But just to keep that checklist in mind, describe the imaging modality, describe the slice, presence or absence of contrast, and describe the lesion and then come to the diagnosis. So you've done everything right. All right. So then we come to Dr. Shefali. Would you want to take this?
This is an MRI scan. It shows a coronal section on the left and an axial section on the right.
Uh-huh.
And we can see ovoid lesion, which is seen in the left eye. And possibly it is within the lateral rectus muscle. And within the ovoid lesion, I can see hyperintensity in the lesion. And
so it's a medial rectus or lateral rectus. I think it's a slip.
Sorry, medial rectus. Sorry, yeah, medial rectus. Yeah. And a void lesion with hyperintensity within the lesion and a very well-defined kind of like a capsule around it. So that describes the scans. And my differential would be cysticercosis.
All right. Myocysticercosis is the correct investigation. All right. So what is in this case, what lesion is what type of images are these?
Type
T1, T2.
Like that. Okay. So it is the axial scan shows a T2 image. Vitreous is hyperintense on T2. So we can see vitreous cavity hyperintense. So T2 imaging. And with contrast, because I can see the blood vessels blooming.
That's correct. So it's important to know the presence or absence of contrast and to mention that, because when you say that clearly, then the examiner knows. So basically in T1 images, the MRI enhances the signal of the fatty tissue and suppresses that of the fluid. So basically everywhere there is fluid like vitreous or CSF, that will be suppressed in T1. Whereas in T2, it will appear hyperintense because it enhances the signal of water or of any fluid. So vitreous, CSF, all are hyperintense in T2. And when you see muscles taking up contrast, especially in T1, when the muscles are showing hyperintensity, then you know it's a T1 with contrast. So that's how we'll come to that later.
So, sir, can I add a question there in the previous slide?
Please.
So this is very classical scan which sir had shown. So the previous one, yeah. So whenever you have this suspected cysticercosis, what is the next line of the management that you would like to do? What else you want to image, which is already done in this scan? After you found something in the medial rectus, do you want to search anywhere else in the body or you don't want?
So intraocularly for any subretinal lesion.
Okay, I think that should have been seen in this image itself.
Yeah.
I think anywhere else, little above the eyes.
So it's
Yes.
always mandatory to do a
The
screening
MRI
of the brain.
Brain.
Because you want to rule out
Neurocysticercosis.
miliary cysticercosis, which can also involve multiple small lesions in the brain. All right.
That
So
is very important. Yes.
this is who's next? Shubhav, back to you again.
Yes, sir.
So here I've given you the a bonus of a clinical image along with the scan.
Yes. There's a clinical photograph on the left showing abaxial proptosis with fullness of the upper lid. And on the right hand side of my screen, there is a CT scan of the which shows a coronal section of the with the lesion confined to the superior lateral aspect of the left orbit, showing hypo dense and
So you can call that as a fluid level.
level. Yeah.
Right. So why is it hypodense?
On a CT, air and fluid, they are hypodense.
Air and
Air
fluid.
is hypodense.
Okay. What is the other thing that is hypodense that you can see? What acts as the contrast material for the optic nerve and the muscles to show up? Fat. So
Fat.
yeah, so fat basically, they're all radiolucent in these cases. So if you're seeing an empty a cavity or a mass lesion which shows up as black, it is most likely including it's a fluid filled or a most likely a fat filled lesion. So what is a fat filled lesion there you would see, which is filled with a fluid? So most likely a dermoid in that region. A dermoid cyst. Okay. So Shefali, Shefali, you can answer this. What is this?
Okay, it's a CT scan, axial cut.
Right?
Yeah. And it shows a hyperdense lesion filling the vitreous cavity,
Mhm.
which is almost as dense as the bone.
Uh-huh.
We can give you a clue if you want.
No glue.
Yeah.
This is something iatrogenic.
Sorry?
This is something iatrogenic.
I hope it's not an implant with a COP.
It's not, because you can actually see the choroid and the sclera posteriorly
And-
attached to the optic nerve. So this is a silicon filled eye. And remember, silicon is hyper dense, almost isodense as bone, not as much though. And especially when you can see the retained globe architecture along with the anterior chamber that is filled with aqueous, it most likely is silicon oil filled eye. So this is one of those googlies for the gold medal. So I'll take away your gold medal from the previous round. And what is this that we see? Anyone can answer.
Gold weight implant.
Okay. So this is actually an Ahmad glaucoma valve. The sign that you see is called the hamburger sign in the superolateral quadrants, where you can see the space in between the plate and the valve. And that's the hypodensely space filled with fluid and filled with air. And that is the location where you would have a valve in place. So the hamburger sign, if you see it superolaterally, it's not a foreign lesion, it's not a gold weight, it's a glaucoma valve. And finally, what is this? Or how would you describe this?
It's an exenteration specimen, specifically like lid sparing exenteration. With
So remember, when you see an exenteration specimen, you're going to be asked about types of types of exenteration, which can either be a eyelid sparing, a radical exenteration, or a radical extended exenteration. An eyelid exenteration is typically performed where the bulk of the eyelid sparing the margins are retained and everything else is scooped out from the orbit, typically for anterior orbital or posterior orbital lesions without bony involvement. When you have a radical exenteration, then you also have to remove one or more walls of the orbit. And finally, when you have an radical extended exenteration, is where apart from the walls of the orbit, it also involves destruction and excision of the surrounding paranasal sinuses surrounding the orbit that is involved. And what you see posteriorly, that central little structure, is the cut end of the optic nerve. This, of course, is a specimen that was exenterated because of mucormycosis. And what you can see here is the white cheesy material here, showing how much of the orbit was involved in this. And all of this is necrotic dead material, and therefore we had to exenterate it. All right. So do we have about 5 minutes?
Yeah, I think we have overshot the time, but I think we can we can wrap it up.
So I'm quickly going to run through how to interpret a scan so that we have those pointers in mind. Primarily a CT scan. So when you see the CT scan, always that top left image that you see here, this is called a scout film that tells you the planes through which the CT scans have been taken, the slices. Remember, these are the planes. The sagittal plane is one that cuts you in half with one eye on either side. Coronal slice is from posterior to anterior, and axial slice is slicing you downwards to upwards. And that's how, when you see, you should remember, any plane that is parallel to a sagittal plane is a parasagittal plane. And slices, when you order or request a CT scan, you always have to mention 2 mm cuts, 3 mm cuts. That is the interval between which an image is going to be procured, like you're slicing a loaf of bread. So when you see a coronal going from the front to the back, you will see the globes, then you will see the optic nerve, and then you can see how the orbit is narrowing as it goes posterior. That gives you a sense of the level in the orbit where the slice has been taken. So in the coronal, the first thing, that landmark you see, is the globe. And then on the axial, you can see that. And this is a parasagittal slice taken through the center of the eye, because you can see the lens shadow as well as the optic nerve, the superior and the inferior rectus, as well as the nerve going straight into the optic canal. So this is the way you remember them. This is your coronals, because it's front to back, and axial, which is down upwards, and sagittal, which divides the body into 2 halves with one eye on either side. So first thing, when you see the scan and you have a patient in front of you, is check whether the scan corresponds with the patient's name. Silly schoolboy mistake can always happen, or a simple error can happen when you get a wrong slice or wrong patient slide, CT scan. Check the patient data, confirm whom you're seeing is the same, and keep your eyes open. Most of the time, the scans are self-explanatory. Whether there is contrast, whether it's a plain scan, what is the Hounsfield units. All these are things that are written on the scan, so you basically can see it and interpret it on your own. Check the laterality. The scans will mention right or left or right, so you know which side you're dealing with. And when you see scans, there'll always be two types of images. There'll be a soft tissue images which focuses more on the architecture of the soft tissue while giving you a rough idea of the bone. Now here, there is a lot of bone approximation of signals that doesn't give you the detailed bony structures, whereas a bone window is an attenuated signal where you're able to identify the exact bony architecture. And here, the soft tissue details are lost. Now you can barely see on the image on the right, you can barely see the intraocular or the intraorbital structures like the optic nerve and the muscles, but you can see the classical appearance of the bony cavity with the eggshell kind of surrounding. The other landmark on a CT scan is the lacrimal gland fossa, a shallow scalloping that is seen, and the soft tissue lesion within that is your lacrimal gland. You will always look at the orbital floor because CT is often done for trauma. So look at the orbital floor. Again, that gives you a landmark of what you need to look for. Now, as you go in the coronal slices posteriorly, you will see the four recta and the optic nerve within. Remember, there is an intermuscular septum that connects the extraocular muscles. And within this septum is the intraconal space. And outside that is the extraconal space. The beauty of CT scan is that, like I mentioned, fat is radio opaque, so it provides you a natural contrast or a background against which you can examine the extraocular muscles, and then you can identify whether there is a lesion, compare either side, so you know you have an objective scale to compare the size of the lesions and the muscles. And like I mentioned, once you know whether it's an intraconal, what is the intraconal space, you know where it's an intraconal lesion, an extraconal lesion, or it could be a mass that is both intraconal and extending extraconal. So that's how you need to describe these lesions. And like I said, look at the surrounding bones. Gentle scalloping or shallow fossa formation seen in long-term chronic lesions or mass lesions that are slow growing, whereas bony erosion and acute angles with scalloped edges are seen, with irregular edges are seen in aggressive, rapidly growing lesions. Check for contrast, especially within blood vessels, or if there is inflammation, you would see enhancement. And if there is a tumor or if there is a breakdown of the blood-brain barrier or enhancement because of inflammation, again, you will see leakage. Again, large lesions like this is a case of a CCF, you can clearly compare the dilated contrast-filled superior ophthalmic vein on the left versus the normal caliber contrast-filled superior ophthalmic vein on the right. Now concluding with MRI, like I mentioned, here you see T1 without contrast. Now, and like we said, here in T1, the fat signal is enhanced. And in T2, the signal of fluids or water like CSF, like vitreous is enhanced. What you see above is T1, and you know it's without contrast because the extraocular muscles, which are very vascular, are not taking up any enhancement or showing any enhancement. So how would a T1 with contrast appear? Like that. So now in a T1 with contrast, you want to visualize the optic nerve. What you would do is a T1 with contrast with fat suppression. And that's how you can see the enhancement of the optic nerve because of contrast that has gone. And that is a case of an optic neuritis. So this is how you interpret, just getting a general gist of CT and MRI, and then that's how you can conclude. Thank you. I think that's all the time we have for. We've overshot and gone almost an hour and a half.
Thank you so much, Dr. Akshay, Dr. Sumeet, for being a part of our webinar today. We thoroughly enjoyed being your guinea pigs. And thank you so much for the amazingly described questions and the images, and especially your googly questions. Any parting words from both of you? I know you are a part of iFocus from a long time and you enjoy taking care
part of IPEP. That's how old I am.
Yes. Don't reveal your age.
Right.
Dr. Sumeet, any parting words?
I think just best wishes. And now this is 307 lectures. So I suppose this is equivalent to more than double postgraduate program. So please do watch all the videos from beginning, and they are very interesting. And we have been following this since COVID days. And I think this is a very nice video library which is available for all the postgraduates and even for the fellows. So we should follow and see at least the lectures of our interest.
Yeah, especially the last lecture, OSCE and these cases. If you actually go through these 2 lectures, I think you are done with plasty and oncology, at least the spotters and the OSCE you will be thorough with. Because we don't get to read so much in our post-graduation, at least in such detail. So thank you so much, both of you, for being part of our evening. We have overshot the time, but you had us hooked 1.5 hours. No dinner, but still we were hooked.
No IPL also.
So next we'll meet on May 29th, which is the grand quiz in ocular oncology by our quiz masters, Dr. Mritika Sen and Dr. Rolika Bansal. So see you all. Hope you all tune in and be a part of that. Good night, everyone.
Thank you.
Thank you.
Thank you so much, sir.